It's a pleasure, and I want to thank the organizers for inviting me. Like Casper, I'll apologize for my slides, except he had 19. I have 67. Settle into your seats, take a deep breath. I think when I got the topic, I think the presumption is that people would be for single tier, and I would be the odd person out. But I think what we've got here, if I could summarize at least in my way, you may object, that we have agreement that tiering can be ethical. We've got multiple justifications for it, whether it's Rawlsian democratic equality that we heard about, or a kind of luck egalitarianism with some reservations, or it's Jan's view of a sort of sufficientarian view with some limit. In any case, distributive justice view. I'm going to give you a slightly different view that I think hasn't fully been articulated. But I want to argue that, as I did in one of the questions, the real issue for us, which I am not going to answer at all, is what constitutes the adequate tier? How do we establish that? What are the principles that will inform it, and what does it actually look like in living? And the other one, I think we haven't discussed enough of, and I will hint at several cases, is when does tiering become ethically unacceptable because it undercuts the adequate tier? And here I will go into a little bit more. This may be my version of Jan's position about the limits on the upper tier. I don't think it's about the narrowness. I think it's about the undercutting of the adequate tier. All right, let me begin with this. Sounds like we're talking about tiering. We ought to know what we're talking about. But I think one of the big problems we have here is that we're actually a little slippery on what is being tiered. So one thing is it could allow patients to buy coverage for other services, access to medical services, or actually getting different health outcomes. So there's tiered coverage tiered when there are meaningful differences in the services that different plans cover for a higher premium, or some other patients may be able to purchase insurance that covers more services, better services, has fewer restrictions. Access is tiered when patients with the same needs have different access to medical services separate from the coverage, wait times, and it can be tiered based on difference of insurance, but also other things. We've mentioned out-of-pocket costs, social connections, geography, and those, we can have a discussion about whether they're actually ethical issues there or not. And then we can tier services, actually. Services tiered when the treatment for a certain condition varies by type, quality, based upon the ability to pay or some other condition, right? All people can have access to knee replacement surgery, but only the well-off have access to the most skilled or popular physicians, those in Vail, Colorado, who do most knee replacements in the world, and are widely considered, at least in the United States, the best. All people can have access to hospital facilities, but only a few of us can either have private rooms or can get the privilege to go to the Mayo Clinic or whatever you want to consider the best. So multi-tiered system in all of these, right? The United States is the quintessential model. I think that's always the evil version that people have in mind when they oppose multiple tiers, right? We certainly have coverage tiering in the United States. I won't defend it as ethical, but we have it. Some people have no insurance. Some people have public insurance that's relatively inadequate. Some people have private insurance, and some people are just, they have private insurance with no copays. They work for McKinsey. Then that was a joke. Okay. I'll cue you when you're supposed to laugh, okay? Maybe you're sleeping and so. Okay, there's tiered access. Better off people typically with better insurance can access expensive prescription drugs and devices that many other people can't because of restrictions. They can get a wider range of certain typically not so much preventive services anymore, but certainly diagnostic services, and maybe shorter wait times. And then there's tiered services. Better off people can pay out of pocket for premium care, longer appointment times with their doctors, etc. That's true in the United States. It's hard to find it turns out, to find a single tier system, and that might tell you something about the ethics or at least the social acceptability of multiple tiers. Cuba may be your best example of a single tier healthcare system. Coverage, access, and the services are all the same for everyone. The entire system is state-run, funded and delivered by the government. There's no permission for private hospitals or clinics or private doctors. All healthcare workers are state employees. Under state insurance, all Cubans are granted the same benefit, and resources are distributed only according to health needs, supposedly. There's no copay for any service or resource, and if you've ever walked into one of their pharmacies or one of their clinics, you might say bare bones, but equally bare bones for everyone. A system that is often held up as a single-tier system is Canada, at least in the United States. Canada is often considered the paradigm for healthcare, single-tiered healthcare system, but that's changed subtly. We say here 2 decades, but let me say it actually turns out to be since the very, very start, and I'll relate that. Covered net access for medically necessary services in the country is designed to be single tier, actually by province, because it's not actually a national system, it's a provincial system. National health insurance for necessary services is universal, no payment at the point of service. Patients can't pay out or get faster care for services covered by the provincial health plans. So if the provincial health plan covers a cabbage, you cannot, it's not permitted in the province to have a private system where you can go and pay, or even in the public system where you can pay and get it faster. That's simply prohibited. Quebec is an exception, and we can go into it. But it turns out that there is tiering, because the original health plan didn't cover drugs. Kind of big problem there, you might say. At least in the United States, drugs constitute 16% of our healthcare spend. If you're not entitled to it. Now, many people in Canada get it either by their employer, which is the main way most people get it, or can buy supplementary insurance. And there are some provinces that you'll have to check me, but I believe do cover at least some prescription drugs. The same thing is true in some provinces for dental, vision, and mental health services. So Canada, which had been, and by the way, this exception for drugs, or the fact that it's not covered, true right at the start. So while it's often been held up as a single-tier system, that is simply false if you think drugs are going to be an essential part of any healthcare system. I would again urge everyone to think through, if we don't have a good example of a single-tier system, maybe there's something fundamentally untenable about a single-tier system. And I would say even in Cuba, Fidel did not get the same service as everyone else. Just saying. Okay. Some claim, I thought that the issue here I was going to have to defend against is that the only ethical version is single tier, but here are the arguments against tiered healthcare, the 4 main arguments that I have heard, not here, but in general over time. 1, health is too important for the market. Only non-essential goods should be distributed based upon market influences. Common argument, health is an essential good. You can go back to a number of people who will argue that. It's necessary for pursuing nearly all other goals around which we organize our lives. It precedes other goods because it's required for their attainment and enjoyment. Therefore, it's unjust to distribute health care based upon the market. That's one argument. Need should be the only relevant criteria. right? Medical need should be the sole criteria for distributing health care. It shouldn't be based upon some other criteria like ability to pay. A tiered system is unfair because it treats similar cases differently by allowing criteria other than medical need to determine access to care and services, or the use of services, or even coverage. Third, healthcare is a public good, and it shouldn't be distributed on the basis of ability to pay as if it were a private good, right? So in a multi-tier system like the US, public dollars and taxes account for sizable share. By the way, you don't have to take pictures. I'm happy to share these slides. There's nothing sacred about them. A multi-tier system like the US we spend about 45, maybe even a little more, percent of the medical spending comes from the US, from government, both state and federal government. That's partially for insurance, but it's also for medical training. It's for supplementing research that produces new medications. Public dollars support research, medical education, subsidize the building of hospitals and medical centers around the country, directly pay for a large portion of actually healthcare services. It's inconsistent for healthcare to be a public good in its creation and funding, but a private good distributed by the market when it's consumed. So I think those are the four main arguments for a single tier and against the US multi-tier. And the last one is tiering undermines the basic services. So the argument is that tiered systems create incentives, especially the potential for higher compensation, additional profit for the best practitioners, private hospitals, newest technology, most effective drugs to be distributed to the well-off rather than equally, and especially to those in medical need. The limited resources then are inaccessible to the lower or bottom tier, which leads to inadequate care for those in the lower tiered coverage. I think we had a rendition earlier in the morning of this kind of argument. So I just want to argue that I don't think tiered healthcare is unjust. I think it's perfectly just. As a matter of fact, I think actually we're probably ethically required to have a tiered system. My first claim would be that government cannot and should not provide access to all beneficial medical services. And here I don't just mean amenities. There's no healthcare system in the world that can allow all people to have access to every beneficial treatment. If you don't think that's true today, let me assure you it'll be true tomorrow. And it'll become increasingly true. I will just parenthetically, we had a discussion because of the cuts of the United States from the WHO. We had a discussion with the WHO about how they should advise low-income countries about what services to curtail because they're not getting American assistance, or they're not getting assistance from PEPFAR or from the Global Fund because of American curtailment, right? And Jeremy Farrar, who's Chief Scientific Officer, but moving over to said, look, this kind of problem, right, going to be more common. And then we are adding on, which I'll talk about a little later, GLP-1s, we're adding on gene therapies, we're adding on lots of things that aren't going to be just problems for low-income countries, but they're going to be problems for all of us. Every country is facing a problem. There is no country I've been to, even Switzerland, that doesn't think healthcare costs are a problem for the country. And that tells you something about the need. Yes, Norway may spend 10%, but even the government thinks 11% is too much. And if you went to 11%, people might say taxes are too much or whatever. So I think this is going to be an accepted position, even if some people want to chafe at it now. The principle of justice, therefore, I think actually that neither the maximum amount of a society's wealth be devoted to public services, nor that the maximum amount that's spent on public services will be devoted to health care. And I basically think that we're going to have to come up with a reason for tiering. And I would just say the basic, what I would like to call adequate healthcare services are what should be guaranteed, and beyond that shouldn't. And I would reframe this tiering debate in this way. Justice has an interest in liberty, right? As Rawls notes, the very first principle of justice is about having the right to the greatest individual liberties compatible with the same liberties for others. Liberty is essential. It's not an afterthought of justice. It's not a good to have. And we all want it so that we can create the life that's compatible with our goals. And we can make choices and effectuate how we realize, whether it's our career, our family size, how we spend our time. There has to be a balance between the benefits of goods and services guaranteed to citizens by their government and the financial liberties that allow citizens to pursue their life goals. I take that as just fundamental. There are goods other than healthcare that government ought to provide everyone. A government can't devote all its funds to providing healthcare. I was actually shocked. I forgot who showed the slide. 43% of the British government spending is now going to the NHS or social services or something. It's certainly true in the United States between Medicare, Social Security, Medicaid. The majority of non-defense spending is covered. I don't know the exact amount is covered by government spending. Nonetheless, there are lots of other things the government ought to invest in, whether it's education, defense, infrastructure, social services that go beyond healthcare, climate change, the environment, whatever. It's clear that government can and should pay for some medical treatments, like those that provide insufficient benefits for costs. I think that's actually an easy one. I think the harder one we're going to have to discuss is which benefits don't we think ought to be covered that are even cost effective. And if government isn't covering some of these things, right, is there a reason to forbid individuals from paying for these treatments and services if they want to, as long as they do not threaten the access to essential goods for other people? I think actually the obligation in this argument is put on those people who think we shouldn't have multiple tiers. They have the argument because I have my liberty interest. Now, I'm not interested personally in spending a lot of money on healthcare. I just minimize my healthcare exposure. Doctors, the fastest way to get sick is to go to a doctor. I have a brother, on the other hand, who has, more money than God, and at the drop of a hat, he'll get medical services. And, he had, some headache, MRI of the head, right? He has, if one of his tests come back low or high, right? 27 additional tests to find out why, right? Every time he calls me with a result, I said, why are you a moron? Once he had, he was 40 some years old and he had a calcium score of his cardiac vessels. And he said, what do you think? And I said, I think you're a moron for getting the test in the first place at 40. It just makes no sense. There are no symptoms, no angina, anything. Nonetheless, that's how he wants to spend his money. And he has the money to spend it on. And he's not taking it. We'll get to taking it from other people. So I do think it's actually, we have to defend people's right. I have to defend my brother's right to be a moron. That's basically what I'm doing here, right? And the reason is he has liberty. Forbidding individuals from paying for additional health care services, I think, is both unethical and unreasonable. It forces a leveling down of health care services. Equality is achieved only through worsening the services for some people who want to prioritize their spending on personal health care services for whatever reason. That's their goal. They want to live a long time, whatever. I think this is inconsistent with the value of liberal polity, in which individuals should have as much liberty as is compatible with the same liberty for others. And I think consuming healthcare services above some adequate tier is something people ought to have the liberty to do if they want to. All right. So then I think it becomes clear why the objections to a multi-tiered system make no sense. First one is healthcare too important. There are many necessary goods that are left to the market to distribute. And a just society wouldn't and shouldn't require everyone to have the same food, the same housing, clothing, cars, bicycles, internet speed, whatever you want to put in as the essential packages or necessities of life, right? We don't make it so that everyone has the same housing, certainly not the same food, right? We would consider it oppressive. And the argument, I think Andrew made this point, the argument that somehow these are less important, even from a health standpoint, is pretty hard to sustain. And if we're going to allow food to be distributed on the market, why not, at least partially on the market, why not healthcare? And we do think there should be an adequate amount of housing, food, clothing, internet, and because these are necessities, right? In a just society, I take it that the well-off should be able to use their resources to buy up fancier meals, bigger houses, designer clothes, sports cars, custom bikes. That's me. That's for me. Faster internet, right? We should, as long as people, whatever we consider the right amount for everyone in society, the rich should be able to spend their money as they will. And while there are clearly some medical goods that shouldn't be subjected to market distribution, and I'll get to that, it's not true for all, or I would even say most medical services. Public dollars cannot and should not provide access to all services. Therefore, there will be some services that are non-essential, but still meaningful to an individual who prioritizes health care over spending resources on other things like education or travel. And if you, think about people and who aren't as crazy as my brother, but you've got a new cancer, or you've had a cancer, you've been treated for it, and I'll tell you that the thing that preoccupies people most is it coming back, right? And they may feel around themselves obsessively. The uncertainty of is it coming back is very oppressive to some people. Some people just forget. Other people are obsessed, and every time they feel something, they want to scan, or they want a tumor marker, or they want something to put their mind at rest, and they can't calm the anxiety without that. It seems to me if they're willing to spend for it, that seems okay. So is healthcare too important for the market? I think it's only too important if the additional resources available for purchase do not meaningfully exhaust important medical goods and services or limit access to the essential services that society thinks everyone should have. In other words, if I buy up, right, it can't compromise. It has to leave as good and as much for others, at least for those adequate essential services, whatever phrase you want to use for that tier. And I think this is going to turn out to be a very important limitation on how much someone can use in that second tier. Is need the only relevant criteria? Now, look, justice is concerned with both need and liberty. Both should be accounted for in a fair distribution of resources, including healthcare. It requires people to spend their money on additional healthcare services after all others are assured of those essential services, because liberty is a priority. It's a public good. While public funds are involved in healthcare system, and say in Norway, 99%, right? Public dollars are involved in many industries, including agriculture, airlines, auto manufacturing, right? Subsidies for cars are done. All of that subsidization doesn't mean that those items aren't distributed in the market. I think in Norway you have a very large subsidy for electric vehicles, right? No tax on them or something equivalent, right? Doesn't mean that the vehicles aren't sold on the market. Public funds don't render things like heirloom produce, first-class airline tickets, handmade bicycles, or even electric cars, owning them unjust, even though those things may be necessities. Tiering, undermining that. I think this is a practical concern. I think some of it can be avoided with careful policy making. I will say it's very interesting to me that almost no countries spend a lot of time on thinking about how to do this. And that may be potentially a single big value of a meeting like this, or I would argue a subsequent meeting, to think about how you create policies to avoid that problem and what you do when you can't avoid that problem in terms of access. And it turns out not to be so easy, and I'll get to an example. A final response to advocates of a single tier. Even in systems with single tier coverage, tiering, I would argue, is inevitable, which is why I wanted to distinguish not just tiering of coverage and tiering of access, but tiering of services. Factors like income, education, social networks influence access and utilization of services and even outcomes. So I think I want to argue tiering in healthcare is inevitable because resources are inherently limited. Certain facilities and providers may offer truly superior, novel, or advanced care, but it's impossible for everyone who needs that care to get it. The best hospitals, physicians can't treat all patients, so access will always be tiered. And the inevitable tiering is illustrative by data looking at Canada as a single-payer system. Again, in Canada, whatever the province offers as part of its basic package, you can't reproduce, you can't access through a private system. It's just prohibited. So they offer a cabbage, no other hospital can off the public system offer a cabbage. It's just not possible to get, excluding Quebec, okay? So take cancer surgeries in Canada designed to be a single tier. Studies on waiting times by income group reveal that even with single tier coverage in Canada and no competing private healthcare system, access still favors the well-off. So this is one study about the length of time patients waited for cancer surgeries for breast, colorectal, lung, and prostate. You might recognize these as the 4 largest cancers in Ontario from 93 to 2000, and significant increases in median surgical wait times were observed between income groups, and the lower income groups, surprise, surprise, waited longer than the upper income groups. So you can see that they waited 4% longer compared to in breast surgery and colorectal surgery. This is actually, I think, a little more interesting. Arthroplasty, that's a replacement of a joint, but comparing Ontario with Pennsylvania between 2012 and 2018, so pretty recently. They were chosen because they have similarities in population size, income distribution, etc. Low-income residents of Pennsylvania, all right, the horrible American system, were more likely to receive arthroplasty than low-income residents of Ontario. Tells you a lot about how effective single-tier systems are. So you can see the lowest quintile when Pennsylvania is in the gray, much more likely than in Ontario, and highest quintile also much more likely. So there are problems, differences. This is not specific to Canada. You look at England, and this is within the NHS, not outside circulating around. People living in the most deprived areas of England are more than twice as likely to wait more than a year for elective care that is still covered by NHS than people in the southeast, the least deprived parts of England. So even in places where you have a single tier, or you're working within the single tier in the NHS case, other factors are going into income, educational status, social networks, being able to call up your friends, etc. So I would argue that tiered access can and still does occur when coverage and services are universal and copays are zero and don't influence access. So rather than build a system upon seemingly impossible premise that single tier is even possible, we should proactively build, I think, a more fair and just multi-tiered system. So tiered healthcare systems are unjust when providing different levels of care to different people, but when failing to ensure that adequate or essential health care is available to all. I think that's the premise we do agree to. Maybe there are people who still don't, but I would argue that that leaves us with several important questions. So this isn't about inequality, it's about adequacy. And I think there are 5 core criteria for a just tiered system. right? The essential benefit package should cover an adequate level of health care, and we can, I think, I will argue, one of our biggest challenges is no one has actually defined what an adequate level of care is. I think we spend too much time arguing about tiering and not enough time about what would that package look like, what should be in and out, what are the principles that should inform that. The essential benefits package should be guaranteed to all people without means testing. The essential benefit package should be designed to attract a sizable majority of the population to use it without supplementation to higher tiers. Now, I say this is the weakest of the requirements, in my view. There are some cases I could imagine 50% of people would buy up, and it still would be, the adequate tier would still be perfectly fine. It depends a lot on how cheap the supplementation is, and that depends upon the number of people. Payment for higher tier services and coverage should be made with after-tax dollars, so there's no public subsidization, and should not provide exemption from tax obligations to financially support the essential or adequate coverage. This is, I think, something not fully taken into account in many countries that allow a private tier, like Australia. And there should be easy adjustment of the essential benefits package, or the adequate tier, should be possible in response to changes in technology, data about efficacy, and demand for additional services. Now this, we can talk about this because I do think that a very important point was raised. If you allow access, and a lot of people are accessing those tiers, right, does that somehow become a need or perceived as a need by the population? I think that actually turns out to be a very difficult issue, because then it's very hard to see how you don't cover everything. Tiered healthcare service, therefore, is not unjust, and there's no injustice inherent in varied levels of access and use of services. But there are two critical questions on which justice hinges. The first is reconsidering as good and as much for others. And does this mean in real life? And the second is defining adequacy. So let me spend a little time in leaving as good and as much for others, because I do think this might go to Jan's point. Spending more to access additional or faster services is acceptable as long as it doesn't compromise the universal access to essential medical services and the services people are entitled to. So I think this is the very Lockean intuition that, everyone should, as a matter of justice, have access to the services, and when the rich take more land, it can't compromise people to getting as good and as much. What circumstances and goods should the market allow to influence the distribution? So I think it applies only to essential medical goods. Non-essential medical goods can't rightly be subject to this distributive principle, like the supply of providers for elective aesthetic procedures, the amount of drugs that fail to provide sufficient benefit for the cost, don't have to do it, or an additional MRI or whole body scan. For essential medical goods, there are some circumstances in which it's clearly wrong to allow private spending to influence or determine access. Consider any medical service which is absolutely scarce. Organ transplantation, as far as I can tell, in every society is absolutely scarce. We don't have enough organs for all the people who need them. We certainly didn't have enough COVID vaccines, at least in the first 6-9 months of having a vaccine. So from December 2020 to something like September 2021, every country had a limited amount of COVID vaccines, even the US and Britain, where they were produced. And allowing people to buy up, allowing people, I think, to buy organs violates this principle of justice. I think the only way to obviate that is if you could prove, and you can't prove it in the COVID vaccine case, but you might prove it in the organ case, that if you allowed people to buy and pay people to donate, you would increase supply. This argument is, of course, an ideological one more than an empirical. It has been defended in an ideological grounds. Well, we'll just create a market in kidneys, we'll get more kidneys, more transplants will happen. In theory, in practice, it's not clear. No one's actually shown that that works. There's been some suggestion that it works in Iran. I've never seen reliable data to that effect. And there are lots of reasons to think it might backfire, because people who otherwise donate won't donate unless they're paid. So I think you would have to show not only that that person who can buy it can get it, but that they actually increase the total supply for the system and more transplants happen. There are times when I think this leaving is good and as much for others is less clear. And I think GLP-1s is a very good example. So for the last 4 years, we've actually had a shortage of this medication. Not enough. All the people who might be eligible either for diabetes or for the drugs based upon obesity have not been able to get it because we can't produce enough. Most countries failed to cover GLP-1s, and all countries failed to implement a fair system for allocation of it. Access was determined largely by ability to pay or on a first-come, first-served basis. The novelty, high unit prices, cumulative budget impact, and various cost-effectiveness analysis complicated fair distribution. High-income countries like the US and Switzerland should not have allowed private wealth to determine access to GLP-1s, right? It was wrong to allow the market to determine whether someone could get these drugs, in my view. They should have been part of anybody's coherent essential benefits package. And so part of what I would argue is that when you've got a shortage of supply, there's an absolute shortage because you can't produce enough for all the people, and you view it as an essential benefit. And I think that's true for organ transplantation, for COVID vaccines, and for GLP-1s. The market shouldn't run. It'll deprive people who are just as entitled, or maybe more entitled. We can go into this, but I think I'm willing to make a very strong argument that depriving obese people of GLP-1s to allow people who could buy them is an unethical market. Another, and this may be unique to the United States, although I have a feeling not, is the rise of what we call in the United States concierge primary care. Now, concierge or VIP medicine allows primary care doctors to offer services to patients willing to pay an annual upfront out-of-pocket retainer fee. It's between $1,000 and now there are some docs who $50,000 to see very, very prestigious doctors, and you need that in addition to the insurance coverage. The benefit of that is you can get same-day appointments with that doctor. You have the doctor's personal telephone, mobile phone number, so you can call 24/7 and talk to your doctor, right? And you also are entitled to longer office visits with your physician. This is, it might seem that this is fairly tiered, right? I want to buy longer time with my doctor. I want to be able to call my doctor 24 hours a day. What's unfair about that? As long as everyone has access to primary care. So it's quite clear, no one's entitled to concierge medicine. People can decide if it's worth $1,000 or $50,000 to them. And they get these added services. If there's too much, right, the demand is sufficiently high or the number of concierge doctors sufficiently high, it actually threatens access to primary care doctors. That does seem to me to be a problem with the system, with access to this service. Now, there's a good reason a doctor might want to do this, at least in the United States. The normal panel size, the normal number of patients a doctor treats in the United States is about 2,000. That's even in the Kaiser system, for example. It can go up as high as 3,000 depending upon how sick your patients are. What is it in Switzerland?
The number of primary care providers?
No, the number of patients a normal primary care provider sees.
Yeah, it's lower than the 2,000, 3,000.
Okay, but it is, I will tell you, at least in many countries, according to the OECD, it's around 2,000 in Sweden, for example, right? Concierge medicine allows a doctor to work a lot less, or at least have fewer patients, not necessarily work less because they spend more time, to 400 to 600. So it's about a third. So there's a real good reason you might want to do that. But unfortunately, there's already a shortage of PCP doctors in the United States because we don't pay them enough. And the rise in concierge medicine can impact the access to this service in lots of places. I would suggest to you that we don't know where access to concierge services are undercutting access to primary care doctors for those people who either can't or are unwilling to provide, to pay the money. But the reason I thought of this example is that it's virtually impossible in Washington, D.C. to get a primary care doctor. And we are, because Washington, D.C. turns out to be one of the richest cities in America, we have a lot of concierge medicine going on. And it may be that so much concierge medicine has happened. We're going to try to see, it's an empirical question, and we're going after that empirical question because I think it would provide an interesting example of you've allowed this practice to go on now for about 25 years, and it, over time, might be leading to undercutting the system. The question is how you regulate it then. Do you prohibit it? What do you do? So I think concierge medicine could be a serious problem. It might raise total healthcare costs. There's no current evidence that it leads to any better outcomes or mortality change I think it's a lot of hand-holding for the worried well. But it might undercut the access of primary care doctors for others. So taken together, I think that scarce essential primary care physician time is being distributed based upon ability to pay rather than need, and it increases total healthcare spending without improving health outcomes. There's no justification for us. And it leaves less care and potentially worse care for those with greater or equal entitlement. It also makes, by the way, the working conditions of physicians who aren't in concierge medicine a lot worse. I think this is a case of where it might violate the principle of as good and as much for others, but you need data, and we need to be able to show it. And what's interesting is there's almost no studies of this kind of finding. I'd say that the second difficult question, as I've already raised in this group, is defining adequacy. Fair-tiered healthcare services require there be some essential benefits package that should cover an adequate level of health care to which all citizens are entitled. But we have no, even when we tried in the United States during Obamacare to define what essential benefits package, we came up with 10 broad categories, and that was the lot of it. Does it include IVF? Most coverage systems in the United States don't include IVF. You might want to argue one way or another on it. There are lots of other services you might want to ask about. We're going to face this with gene therapies. Don't cover gene therapies. Lots of places aren't covering, lots of insurance companies don't cover GLP-1s. Medicare's not allowed to. So I think a lot of those judgments are wrong, but we don't have a good in-principle argument. All of us in the room, smartest people in the world, working on this issue, and I think actually this and the first one are very, very important issues that we have not devoted sufficient time to. So determining what constitutes an adequate level of care, right, really difficult, and I think actually very likely to differ between countries. I don't think there's a single package that will satisfy it, as countries differ on how much they're willing to spend. Great Britain, UK, 8% of GDP. Norway, 10%. Switzerland, 12.5%. United States, 17.5%, right? Very different. And I think population preferences and willingness to tolerate some of these value traders make it very unlikely we're all going to have the same package. There will be lots of overlap, but there will also be lots of differences. And I think how we handle that is something we haven't thought through. All right. Anyway, you get the rest of it. I'm not going to go through my summary. All right. If you were sleeping, that's okay.